See who else is joining us. See, give people some time. But yeah, it's I'll be so glad when this COVID is over. And you know, it's very difficult to get to know people that you're meeting for the first time when you meet them in a mask.
That's
because
true.
you can never really get to know who they are, right? I can't hear you, Dr. Kendra. You're on mute. Maybe Dr. Kendra.
And you're on.
Great. Okay.
You want us to mute when we're talking?
No. We're live now, and Ms. Stark, please unmute yourself. I'd like to welcome everybody to the Rodham Institute speaker series. I'm Dr. Gigi El-Bayoumi, and I'm the founding director. We are dedicated to improving health equity in Washington, D.C. The topic that we're going to be discussing today, breast cancer, is something that's very important to me. Over 15 years ago now, I got diagnosed with breast cancer. I had missed several of my mammograms because I was going through a divorce, and which is actually not unusual. Got diagnosed, and because at the time I was 45, I elected to get a bilateral mastectomy. I had 2 large tumors in my right breast, and so I decided to do that. And at the time, we would get chemo after surgery. That's changed now, but then I had chemo. I was ER/PR positive, but also HER2 positive. So that meant that I got a year of Herceptin, a daily IV of, weekly IV of Herceptin. And Herceptin actually had just been approved by the FDA. It was almost a month or 2 afterwards. I felt very fortunate. About a year later, I decided to delay my my reconstructive surgery. I had reconstruction. Usually that surgery takes 15 hours, but for me it took 30. It turns out I have big arteries, but really small veins. That's what caused the surgery to take a lot longer. But I'm very fortunate to be here to talk to you about this issue, which is something that affects all women. 1 in 8 of us will be diagnosed. However, even though 1 in 8 of us will be diagnosed with breast cancer over our lifetime, not everybody has the same results as I did. Because of my class background, my privilege as a physician, I was able to navigate the system very quickly. However, we know that statistics are not the same for women from Black and Brown communities, from poor backgrounds. And so sadly, in Washington, D.C., and this is going to be the topic of our discussion, the outcomes are much, much worse. And the disease is actually more aggressive, especially in African-American women. But I'm not going to be talking on a monologue. We've got 3 excellent guests, and I'm going to bring them on one at a time. Let me see. I will do this alphabetically because you're all equally wonderful. So we'll start off with you, Ms. Thelma Jones. It's so nice to see you with your beautiful self. Can you tell us about yourself?
Thank you so much for inviting me to be a part of this exciting event that I know people will walk away with some nuggets and helpful hints and tips. So a bit about myself. I was diagnosed as HER2 positive in June of 2007. I had passed up doing mammograms for a few years because I was very busy at work, somehow thinking that if I went to the doctor, that maybe life at the World Bank would collapse, which is where I retired from after more than 33 years. And I had retired, was actually enjoying part of my retirement benefits studying Spanish in Santa Ana, Costa Rica, and I noticed this lump just before I was leaving, and I thought, oh, well, I'll deal with this when I return. I returned after about a month in Santa Ana. I went on 3 or 4 other trips. And it was March of the next year, 2007, that I'm at a speaking engagement in Philadelphia and I'm showering and this lump is just quite pronounced. And I thought, you need to do something about this. The result was that I was diagnosed with a late stage 3B of breast cancer with an unknown primary HER2 positive, which, as we know, is an aggressive form of breast cancer. And going through that, I did, as you mentioned earlier, you did, well, we do neoadjuvant treatments now. And that's what I did because the tumors were very large and matted together. We decided that neoadjuvant treatment to shrink so we could see the lay of the land was the best option. So I went through several rounds of long hours of chemotherapy. I remember once being there for like 6 hours. And afterwards, I had surgery, a lumpectomy. We discovered I had 34 lymph nodes that were either cancerous or did not clear the margin. Then I had 7 weeks of radiation and then hormonal therapy for 10 years. And as a result of this daunting experience, I pray that if I went through this, I would dedicate my life to the message of early detection and helping to prevent, hopefully, that others will go through what I've gone through. And I created the Thelma D. Jones Breast Cancer Fund. And I'm pleased to say that, Gigi, you have been a speaker there at least 3 times, if not more. So.
And I will continue to support the great work that you do any and every time, because you're really a source of inspiration for me personally, but also all the great work that you're doing, Ms. Thelma, is just unbelievable. You're a source of information, knowledge, but also comfort and healing. So thank you. I'm looking forward to talking some more. Next is Dr. Kendra Outler. So Dr. Kendler, can you please tell us about yourself?
Hi, and I just want to say I'm just so pleased and I'm honored to be in your presence. As a physician, as a woman of color, African-American woman, I'm just humbled. My experience is that of the silent observer, that breast cancer is a shared experience, and that, you know, whether you're a mom or girlfriend, I'm sure you all have moms, girlfriends, loved ones, we are looking at you go through a very difficult period. And my grandmother was diagnosed with breast cancer. And I remember that as a child. I was telling Dr. Gigi, I remember watching Soul Train and seeing Minnie Riperton cry her heart out in a song, Back Down Memory Lane.
Oh, yeah.
I was probably 7. I didn't know what she was hurting for, but I knew something bad was going on with her, right? And then, you know, you keep watching Soul Train through the years and you put it together through medical school, and then you relate it to your grandmother. And then I had a dear cook at my school that had breast cancer, and I couldn't understand why we were not getting better. I mean, I knew my grandmother was older, but why was this 42-year-old woman in the prime of her life not getting better? And then when I was like, give me the paperwork, and I saw those words, triple negative breast cancer, called the doctor and said, I don't know what this is. What are you trying to tell me? And to watch her suffer, not really knowing that she had a different type of breast cancer. Her sister oddly had died. This is an inner city Atlanta Black family through and through. And I'm looking at, then it makes sense, the sister died. She is not going to make it. And so, you know, I saw her children, her grandchildren, because everybody started having children young. And, you know, watching as we watched her go through her cancer and make a sick room, and, you know, somebody's frying chicken and somebody's laughing and somebody's playing dominoes. So I come to you as an observer of the life and the strength that we have to witness when we have a loved one going through breast cancer. So I have a project that I started, Uzima Health and Wellness, and during the pandemic, precisely to make sure that we keep a pulse on these things in the Black community that disproportionately affect us. And triple negative breast cancer does. So October is one of those months where we saw an uptick in the conversation. And this year I said, you know what, we're going to keep upping the ante in terms of this conversation. So I created the public service announcements that have gotten very good reviews. I have women texting me saying this is what I needed to see. I needed to see girlfriends encouraging each other to get a mammogram. I needed to hear a husband say to his wife, it's been 15 years. I still remember when you called me. We have 3 sons. They were 5, 6, and 7, and just, hear his voice, recollect that moment. And then, then I have pink reflections where I think about what if my tomorrow was different? And what is it that we always think about? We think, well, will I put on a wig? I mean, how am I going to go at this? And so you look at yourself in the mirror and you think about your loved ones, your girlfriends, and you just know that if it comes to you, that you have examples of strength to keep going. So I think that also Dr. Gigi and I can relate that, we have access to the medical community, but that doesn't guarantee a good outcome. And I think that that's what we have to remember as Black women, that it doesn't guarantee a good outcome just because you're a doctor. And so that's a very frightening thought, that genetically we are predisposed to this cancer. So that is my platform. That's my mission. That's something I want to continue to talk about. Because I know that from watching, Soul Train, that she left behind 2 lovely children that actually gave us a gift of comedy and art in the world, Maya Rudolph and her brother. And it all makes sense, that we have moms leaving children and husbands that are widowed, or partners even, that are widowed. So I'm pleased to join this group of women who advocate, women and men who advocate for this mission of breast cancer awareness.
Thank you so much, Dr. Kendra. Last but certainly not least, Ms. Elizabeth Stark, geneticist. Can you please introduce yourself and tell us what your inspiration is in terms of doing this work?
Yeah, absolutely. Thank you so much for the invitation. I mean, anytime we have a chance to talk with a group of women who are so passionate and so driven, we absolutely want to take advantage of that. I came to genetics saying I would do anything but cancer. I came saying I will do literally anything else because I just seen too many people in my family die. And when I started learning about cancer genetics, when I started learning that there's a way to have conversations about prevention, when there's a way to actually change the family narrative, when there's a way that, my grandparents' generation, my parents' generation doesn't have to look the same for my generation, that's when I really got passionate about it. And so at GW, I'm the director of our Cancer Genetics and Prevention Service line, and we really have a focus on access, on education, and on making sure that we are doing our part to try and decrease disparities wherever we can. And so we are doing things like starting telegenetics models so that we can try and eliminate some of the barriers of transportation and childcare and parking, some of the things that get in the way. We are trying to meet people where they're at whenever we can. We are grant funded by a woman who didn't want money to be a reason someone doesn't have a conversation about genetics. So we are actually able to see anyone regardless of their ability to pay. And we have really great relationships with insurance labs where we can help get the testing covered as well. So we're really trying to make sure that we're addressing the areas that we can. We actually went to and we did some research in our breast cancer community. And we said, what are the differences between referrals for different groups and what's impacting that? And when we took a really hard look at our practice, we found that the only thing that mattered of which breast cancer survivors were referred to genetics and those who weren't was their race. And it was referral by physician that made the difference. And so we had to take a really good hard look at our practice and say, how are we going to change that? How are we going to make sure that we're reaching out and getting the information into every community that wants to hear it about what we have to offer? I've sat with so many women, grandmothers, mothers who say, I'm doing this, but I want to do this so my kids don't have to. And so that is what I'm most passionate about, is trying to make sure that everyone understands what their options are and how genetic testing isn't about telling someone they have cancer. It's not telling someone they're definitely going to get cancer. It's personalizing their care. It's taking advantage of the information we have so that we can hopefully prevent things in the future.
I also understand that one of the, I don't know if it was a study looking just at GW or just overall, and please clarify, that it turns out that African-American women specifically want to get genetic testing at the same, if not at a higher rate than their white counterparts. Is that correct?
Yeah, absolutely. We aren't seeing any differences in that. The only difference is a physician starting that conversation. And so sometimes, because as much as we try, we can't reach everyone, we need to empower the women. Because if they bring it up themselves, then it's just much more likely to follow through. And so we know that sometimes a woman advocating for herself is going to make the difference. And so that's where we're putting a lot of our effort.
And the implicit bias of not everybody getting the genetic screening offered to them. Well, there's already somebody in the chat that's asking about triple negative and BRCA genes. So Dr. Kendra, what is triple negative breast cancer?
Well, we think of triple negative breast cancer as the type of cancer where cells proliferate. That's the part of this cancer. And the cells that are growing inside the woman's breast tissue do not have receptors so that we can target a cure. There's no estrogen receptor, there's no progesterone receptor, and there's no human epidermal growth receptor there. That's a protein. So you have two hormones and a protein. And so when we think about treating it, we want to target these hormones and we want to target this protein, but we can't. And so what we typically do is have chemotherapy agents which can stave off the growth of the cells. But the challenge with triple negative breast cancer is that you end up with recurrence. You end up with also chemotherapy resistance, so that you have a relapse in metastatic disease within 5 years. And so that is what the disease is. We don't know why it is predominantly in younger African-American and Hispanic women would be the second group. We don't know why. I think that's what we're leaning on Professor Starks, Dr. Starks to teach us. There's a lot of aggressive research about why. I think that's why it's important for us to understand the urgency to changing the message to Black communities and Hispanic communities that you need to get your mammogram done earlier if you feel something, at least by 40. And there are some advocates who say, because of this aggressive disease, that we may need to change the screening protocol for Black and Hispanic women to an earlier age. What that age is, we don't know, but there is conversation. So that's why we need advocates to say, I think that'd be the best decision to get an earlier start.
You know, it is so confusing out there because you've got different groups that are advising, are having advice about when to start the screening and how often to start the screening. And these recommendations are based on populations. They're not based actually on individual either ethnic groups or communities. So let's take something that's not related to breast cancer. The US Preventative Task Force said, you know what, you don't have to worry about prostate cancer screening in men. Well, that caused an increase of prostate cancer in Black men, because we know that we should start screening at age 40 and not 50 in Black men, because it's more aggressive and starts earlier. So I think that, you know, when one is discussing when to begin screening, we know here at GW, we actually start at age 40 if you're at average risk. If you have a family history, that's different, and that conversation needs to be individualized. But I'm going to come to you, is it Dr. Stark? Forgive me if I'm not addressing you properly.
No, Elizabeth Stark. That's
Okay,
thank
Ms.
you.
Stark. Are there genetic markers for triple negative breast cancer? And what
Yeah,
are the genes that we check for in general?
no, it's a great question. So BRCA1, or sometimes called BRCA1, is more associated with triple negative breast cancer. For a woman who has a BRCA1 mutation, about 2/3 of the time, if she gets breast cancer, it's going to be triple negative. And because of that, the National Comprehensive Cancer Network has recently changed their guidelines to say that any woman, regardless of her age of diagnosis, regardless of her family history, if she has triple negative breast cancer, she should absolutely have genetic testing because we see so much more of BRCA1 with triple negative. Now, we're also starting to realize that there are other genes that we look at where if you have a mutation, it's going to predispose to triple negative breast cancer as well. So genes like RAD51C, RAD51D, there's a whole host of genes that are associated with triple negative breast cancers. Now, there are some genes that are associated with triple positive breast cancers. We have some genes that are associated with kind of the ER/PR positive, HER2 negative breast cancer. We have moved away from a single gene testing model. When I started our program at GW with Dr. Kaltman a number of years ago, we were looking at 2 genes, BRCA1, BRCA2, that's it. Today, I'm commonly ordering a panel of 84 genes, and that's just over the past, I think, 9 years that shift has happened. And so there are so many different genetic factors that we're looking at.
And, for you and I, Miss Thelma, we got diagnosed a while ago. I wasn't even offered genetic testing. And so things have really changed. And in a field such as cancer, that's why it's important to talk to people who are knowledgeable about these issues and not just rely on, sort of word of mouth. But Ms. Thelma, you went through a recent scare that I know that you wanted to talk to us about today. Can you share that? You even have some pictures that you have. Can you
Yes,
talk to us about what happened?
absolutely. I was visiting my medical oncologist and to share with him that I was concerned about a lump that I had beneath my right arm, which is also the same place that my breast cancer diagnosis occurred. And when he sadly said, yes, I feel the lump, and because of your history, we really should get it checked out. So that was about 2.5 weeks ago. So for 2.5 weeks, I felt as though I've had the world on my shoulder and pretty much not sharing it with a lot of people. And fortunately, I guess going through Breast Cancer Awareness Month helped to keep me occupied, but that nagging thought was always there. So today, just this morning, I underwent a mammogram and an ultrasound. And when my good partner in crime, as she agreed that we should be called each other, Dr. Rachel Brim, advised me that I don't see anything. And it was almost like, when you inflate a balloon, I just felt so relieved that I probably couldn't even share how relieved I was. I was more interested in getting pictures taken so that I could help to alleviate that fear and scare that people put off and don't go to the doctor when they know something is wrong. Early detection saves lives. And I could have felt that lump and kept thinking, oh no, it's not really anything, but I'm not a medical doctor. So why should I be diagnosing myself when I could help to alleviate some of all of that stress that I was carrying? So my mammogram and my ultrasound, which is here, both came out okay, but I still need to do an MRI to just compare it with my last MRI. And but I do understand why women and men, because men get breast cancer as well, are fearful of this process, because it's the thought of what's next. You know, does my life get turned upside down? You cannot imagine the things that I had started tentatively planning. For instance, I'm getting ready to go to my high school reunion, and I was about to go to my college reunion in 2007 when I had the scare that became a reality. And I said to my doctor, well, should I cancel the reunion? And he said, no, you want to go and you'll need that. So I'm just pleased that I am here to say that I'm okay and I can continue the mission of the Thelma D. Jones Breast Cancer Fund, which is essentially helping with outreach, education, and support for incidents like this, and carrying the message of early detection saves lives.
Yes, it does. And thank you so much for sharing, because it's those personal experiences that make a difference. I remember when I felt my lump, I said, is this what I think it is? And then I said, no. And then I said, you know what? I can't know. So I've got to get it checked out, because I was like many women. I had very, most women have fibrocystic changes in their breast, but somehow this felt differently. And it doesn't matter if you're a doctor or not, believe me, because I'm like, maybe I should just not worry about it. But Dr. Kendra, you have had that easy kind of conversational style of sharing stories as a part of your campaign. I don't know if you have a PSA that you had mentioned before that you can share with us, because it is so powerful.
Well, we could load it up. It's Ashanti is, and I'd love to show it. And while we get that loaded up, Ashanti, I did want to say that what I'm finding when I do health fairs and get out in the community, different communities have a certain style in which they want to interact. And I find that what we found in public health is that when you go to Black communities where they are most relaxed, they are more receptive. So that's why it's been very impactful to have hypertensive training by barbers. I'm not the messenger, let the people be the messenger. Set the tone, give the information, and let them set the dialogue and the way they want to converse. And just kind of guide and navigate. And I think that, the medical communities can sometimes be tone deaf to that process. And then we kind of say, well, that's not exactly what they know what it means in this type of a cultural way of communicating. And so, that's important. And that's what I try to do. Just tell the story, just relate it to everyday. This is when I'm with my girlfriends, or, I just came in and I still have that picture and I have this moment, or I see a lovely couple and you think about, life. So that's how I approach Uzima with all of my pieces. And so it's resonating, and I'm just so thankful that I got it right.
Yes, you did. Yes, you did. So here's one. It's called Go Get Your Mammogram. Let's take a look.
How's the game?
It was so good. Those fans were marching. Just the energy, the spirit, and friendship.
Really?
Just felt good energy.
Hey, Jay.
Hey, Jay.
How you doing?
Good.
What you do today?
Dropped that boy off at school.
Chooks?
Yes. And then I had to stop and get a mammogram.
You got a mammogram today? You got your breast exam?
Yes.
You got your breast exam.
I got my breast exam and
That's good.
Was it hurtful?
ill.
It's important though. My mom passed away from breast cancer, so it's so important that we get our breast exam.
It is.
Just a little bit of pain, but then it's really worth
so
it.
much.
It's not medical talk, it's sister talk. Something that casual and simple can be life-saving. Go get yourself checked. The CDC recommends that women have their first mammogram at 40 years of age. I had mine at 28 because I felt something and I had a family history. Early detection of breast cancer can mean a better treatment, better survival. Let's find a cure for triple-negative breast cancer.
I love it. And there are so many more that I would really invite people to visit your website. You know, I was on a panel with you, I guess last Tuesday, and you said something that really resonated with me, that as friends, as people, you know, who have loved ones, you know, girlfriends, you know, sisters, aunties, grandmothers, moms, neighbors, that especially when you see somebody who's going through a hard time, in my case, it was a divorce, it's important to have somebody say, you know, are you taking care of your health? Have you gotten your mammogram? Because when you're dealing with these things, you are the last on your list, right? So can each of you sort of speak to that? And we'll start off with you, Dr. Kendra.
You know, I had a pleasant experience this week. I'm an anesthesiologist. My primary residency was in family medicine. And so that has helped in the sense that I typically will ask more questions than, do you have any questions about your anesthesia? You know, so I had a delightful lady that was avoiding eye contact. And I said, you know, do you do your walking program? You're retired. She's worked hard for the military. She, you know, I'm like, what do you do to stay active? And then she kind of waved and said, you know, I kind of do things around the house. For, you know, my family medicine background kind of kicks into gear and say, you're 60. Why is that just kind of a wave off? Why are you not socializing with friends or have a nice walking group? Or maybe you and your husband have a hiking trail. And note that COVID has made a lot of these activities very difficult. So I'm also asking for that reason. And, you know, she said she had her kids late in life and she had 4 and they were lined up. She had 2 seniors because they were twins, a sophomore and a freshman in college. And I said, oh, you're busy. So needless to say, the surgery we were doing for her was one that she had been putting off and putting off and putting off. And so this is the same thing that we see over and over again for working moms. And, you know, women in general, caregivers, got to keep going, got to keep doing these things. And I think that as healthcare providers, and what I try to teach my residents is just pause, you know, stop rattling off the checklist for what you need and make sure you're taking a moment to look at your patient. If they're telling you something and it's as simple as, I don't even have time to work out, because for us, that tells us conditioning, right? I'm about to put you to sleep. So it's important in that respect. But it also gives me a chance to do patient education to say, I understand you're busy. I know the kids are graduating. I want you to have a great senior year. And I also want you to start back a walking program. Can you just give me one more day during the week? And they usually smile and then they feel comfortable that you're not just putting them to sleep, but you actually care about them. And I think that before you give your drugs, you've now made a difference in someone's life.
Mm-hmm. You know, I think that is such an important point, is just in whatever settings and whether we're talking about work or our social life or, you know, in our church for people who go to church or mosque or synagogue, whatever setting, is that for us to be human and to have those conversations. I mean, I think now the way that our society has become, everybody's reading from a script, right? And we're losing sort of that human touch, which is so important. Ms. Thelma, what are some of the barriers that you're seeing for getting those mammograms or getting, you know, being concerned about breast health or health overall? What are you seeing in the work that you're doing, especially if we can focus since COVID has come, because that's really been sadly a game changer in the negative.
Absolutely. And some of the barriers that I am still seeing is women are too busy. It's not a priority, or we say to ourselves and everyone else, I know I should be doing it, but we're not. Another one is still the fear factor. And it's not just fear that it's going to hurt. It's not just fear that I'm going to lose my hair. It's also fear of, you know, I'm dating, I just met a guy, or I just got married, or I have a new partner. Is my partner or significant other going to leave me when I find out, when that person finds out that I'm dealing with breast cancer, because we know the reality is that some partners do walk out on their mate when they discover this. There's also the fear of, but I am the person who uplifts and holds together my family. So if I go to the doctor and I'm incapacitated, who's going to take care of my children? Who's going to do my role on my job? Who's going to lead the choir at my church? Who's going to do the things in my community? We can think of everything about what will happen if we stop to think that taking care of ourselves is important, because we can't be everything to everybody else if we've allowed ourselves to collapse. I mean, we have to learn and to understand the world around us, even our children and significant others, will wait. And who knows, hopefully they will even support and encourage us to take care of ourselves, because they realize that we're the pillar of strength in the household. So those are some of the things that I'm seeing. And this is why we love having great speakers like you, Gigi, to come to our support group meetings so that women can hear, and men, a variety of things that can help to support their lifestyles.
Well, thank you for that. You know, one thing that I think sometimes we as women, we put so much on ourselves, but we forget that we're being watched. We're being watched by younger women, by kids, by girls, and so also, what are we modeling by saying I'm not taking care of myself? You know what I mean? So how we impact not just for our own personal health, but what are we really teaching others? So if you're not caring about yourself, actually caring for yourself is a way of caring for others. So I think that, the messaging around, sometimes, when people are fearful of things, I'll just say, let's go there. Let's think about what those fears are. Okay, I lost all of my hair. Turns out I have a really pretty shaped head. There was something, I want to tell you, there was something liberating about not having hair, because, I couldn't, for me and like many, many women of African descent, hair is a barrier, right, for exercising. I didn't have to worry about that. And even a mastectomy, bilateral mastectomy. I was one of these people that had huge breasts, and it was actually a barrier to exercise. Even though I had I had a reconstructive surgery, when I had that year of not having any breasts, it's like, wow, this is great. I can wear whatever I want. I don't have to worry about a bra. But, and I'm not meaning to minimize concerns, but sometimes going there in terms of what is the worst that can happen, it's like, okay, we're gonna deal with that. It's not easy, and as many people in the audience know, I had to deal with another cancer, kidney cancer, this past year, during COVID. But you deal with it, and it's not easy. I'm not meaning to say that it's a walk in the park, or I would wish it on anybody. I don't. But there are things that we just have to deal with it, and that's where you really dig down deep in sort of that core. You lean on your friends, you lean on your family, certainly the people that you love and love you, and that's where our resilience comes from. Ms. Tark, there's so much in the way of misconception about genetics, and I remember there was actually a time when people were worried that the genetic information would be used against them in terms of preventing them from getting insurance, or that the insurance rate would get hiked up if a person had a particular gene. Can you speak to that, please?
Yeah, absolutely. And that was a real fear that we had for a number of years. I remember at my first job out in California at UCSF, we ordered testing under fake names because we too were worried about what those implications were. But in 2008, there was a law passed called the Genetic Information Non-Discrimination Act, or GINA. And this 2008 law was passed under a Republican administration. It has no ties to the Affordable Care Act, which is important because we know sometimes that feels like it could be under attack. And that said that health insurance cannot use your genetic information against you. They cannot call it pre-existing. They can't raise your rates. They can't drop your coverage. Health insurance is very, very, very well protected. When we think about a gray area, we know that life insurance, disability insurance, and long-term care insurance is not explicitly protected under that law. Now, we aren't seeing any cases of people being denied insurance. There are no reports of discrimination coming through, but I also don't have a crystal ball. So when I meet with people, we talk about like your health insurance is safe. I am not worried about that. If some people feel like they need to go and get a bigger life insurance policy or something like that, I'm happy to help them think through the timeline and all that sort of thing. But I don't want anyone worried that they're going to lose their health insurance. It can't impact their kids' health insurance. Health insurance is incredibly well protected.
So when sometimes on the genetic testing, you find that you're at risk for other cancers.
Yeah.
Can you speak to that?
Yeah, absolutely. And so when we think about genetics, we think about prevention, we think about targeted therapeutics. So for example, a BRCA1 carrier with triple negative breast cancer has an extra chemotherapy they can get that's more targeted for their cancer. But then we think about the word and. With BRCA1, it's breast and ovarian cancer. With POLB2, which has been in the news a lot, it's breast and pancreatic cancer. And the and comes in when your team gets you through a cancer diagnosis. What are we going to do to make sure that you don't have to do this again? Sometimes it's considering really big conversations, like potentially even having ovaries and fallopian tubes removed. Sometimes it's pretty small things, like let's do a colonoscopy every 5 years versus every 10 years. It's all about personalizing that care and making sure that we're giving you the best possible plan to try and decrease your risks.
That's very helpful. Dr. Kendra, you look like you wanted to add something.
Well, I want to ask a question. I think that, we recognize that we are, that this is a big institution with a lot of funding. And I think that in part of the conversation that we have with in various communities, as you mentioned before, and educating me about the DC community, and we look at what we call health deserts across the DMV, where, if you're in Anacostia, your access to care is very limited. And I've been very confused as to how, certain pockets of PG County, Anacostia, St. Charles County, how these communities actually get to well-needed services such as genetic care, and how would they get these services, mammography, and so they're actually left to basically have this kind of patchwork healthcare provided as they get referrals. So, that is very frustrating to people who may not have transportation, or even if they have transportation. One doctor told me that some communities, they move to Waldorf, but they drive back to Washington Hospital Center. And so as we see these shifts, how are we as a medical community safeguarding them?
Mm-hmm. Well, I can tell you that unless you're doing that deliberately, it's not going to get done, right? So for us at the Rodham Institute, and Ms. Thelma is a member of the citywide breast cancer collaborative. However, we are also doing mammography through the mobile mammogram program, so that we actually, Ms. Christina Williams, who's the head of our community engagement, signs up people so that we go to the church and we can make it convenient. But I think, the point that you made earlier, Dr. Kendra, is crucial. Educating communities so that communities are the ones that hold the educational information, the social, economic, educational, and political power is held by the community, and increasing that capital becomes key. So what we're doing with our various partners, be they church or otherwise, actually working to embed programs there so that you're training people to be ambassadors, because there are, as you've mentioned, all kinds of barriers to education, just our communication styles, not necessarily being culturally sensitive or culturally, relevant even. So what we did, and we did this for our mass vaccination event that we had in April at the Southeast Tennyson Learning Center, where we vaccinated almost 900 people on one day. What we did is that we did the train the trainers, 9 90-minute sessions to just educate people who serve the residents of Ward 8 about COVID vaccinations. Because guess what? When we're gone, that information is still going to be there. That information will still be there and will shared and other people on days not on the mass vaccination day. So I think a couple of things need to happen. You know, we sadly, we're in a medical apartheid system. Let's just call it what it is. The outcomes are worse for people if they are Black and brown, and we can go on down the line. There's so many groups that are left out. And so it's important that we really relook at the whole system, because it's not working the way that it is now. Why can't we have mammography units that are in either mobile or in communities so that people don't have to take 3 bus rides to the other side of town? Why can't we make it so that, for example, pap smears, do you know that there are actually pap smears that can be self-administered at home and you don't even have to come to the doctor? Why do we have to have things set up the way that we do, where only an elite group can access this? I consider myself part of that elite group because I'm a physician, right? When I had my cancer, when I had the blood in the urine, I could call up my friend and say, look, can you get me into a CT scan? That's not the way that it should be if we're calling ourselves a democratic society. So I couldn't agree with you more. But just like what Ms. Stark said, first of all, from the standpoint of the medical healthcare community, putting a mirror up to ourselves and actually looking at what our practices are and being honest about what the disparities are. That's one. But also, you know, changing the locus of power so that it's actually the community that has the power and not everything being in the hands of the healthcare system, because it is failing a lot of people. And frankly, COVID is making it even worse. I don't know if other people want to comment.
So I'd actually love to comment on empowering the community greater. So we talked about the different ages that we start mammograms, different groups have it. We at the Thelma D. Jones Breast Cancer Fund really believe in early detection, like all of the rest of you do. But we are finding, because African-American women are developing breast cancer at a much earlier age, so waiting to tell them about that 40 business may be a little bit too late. So tomorrow, I am pleased to say that the Thelma D. Jones Breast Cancer Fund will train a group of cheerleaders at the Richard Wright Public Charter School. So we're starting at a younger age with age-appropriate information, and thanks to the Prevent Cancer Foundation assisting us with that. And we're going to train and empower those young girls to be ambassadors in their schools, at their home, and in their communities, to help to educate them about the importance of early detection. So I think that just speaks volumes to what you were saying, Gigi, about empowering the community and recognizing that medical centers that you have to take 2 or 3 buses across town, deal with childcare, may not have bus fare, or may just don't feel like dealing with the system that we know to some extent it is broken. So training young women like that, I just think that's going to be a wonderful thing. And we hope to grow that effort throughout DCPS and Montgomery in Prince
Yeah.
George.
And thank you for that. That is exactly, I think, what needs to happen, and of different groups, not only kids that are, but or people that may be in the school system, but let's not forget people that may have dropped out of the school systems, right? You have in Ward 8, only 42% of people even finish high school. So how do you capture those groups? Because there are, groups within groups that are even more vulnerable, right? Like the homeless or, returning citizens, et cetera. But one of the things that I think is going to be key also when it comes to breast cancer and prevention is the idea of what constitutes good breast health, including breastfeeding and including diet and exercise. I think, Ms. Stark, if you'd be kind enough to talk about epigenetics, because I think that that's not really something that the public is educated on.
Yeah, absolutely. So epigenetics is the idea that things and genes can be turned off and on, and it's impacted by our environment. And so there's a whole list of things that we know can impact our epigenetic genome. And we're trying to right now really figure out what are some of those things. So we know even generationally, there are things that can be passed down epigenetically. We know that diet, we know that exercise, that all of these things are playing a role. And so if we can try and get some of those pieces in place, we're hopeful that it'll help decrease rates overall. But it's a really exciting area of research that's starting to bear fruit.
And that's really important because when you are diagnosed as having some genetic predisposition, it's a predisposition. I'm not talking about people who've been diagnosed with cancer, but somebody who may have a gene because their loved one was diagnosed, so they got tested. So it's not an automatic that you will get come up or have that disease. That there are actually things that you can do. Yes, Dr. Kendra.
Well, I wanted to comment with Dr. Starks, Professor Starks, and that is that, there, in terms of discussing the social determinants of health, there are things we can't change. You can't change your race, you can't change the zip code that you belong to. I think that but there are things like we said in terms of breast cancer prevention or causation. I think diet has been definitely clear. And that if we can control obesity in this area, that this is not a vain conversation. And one of the studies I saw out of University of Chicago is looking at sugary diets as a driver for triple negative breast cancer. So then that has real community implications as we look at certain communities of color, our communities of color, that they don't have access to healthier foods. And so while we want people, of course, who, to lose weight and to eat fruits and vegetables, the reality is that a lot of these communities lack some of these basic things that maybe we can change, which you're discussing in terms of altering genetics. But if you have children who are growing up on high fat, sugary diets because that's what is served in their communities, this is an opportunity to intervene on one of the social determinants of health. So I just wanted to, and I think that was kind of the play off what you were saying. Is that correct?
Yes.
Okay.
I think so. I mean, and that's why when you look at activists in the community, such as the Ward 8 Health Council, they bring in the food piece. They are trying to build co-ops. They are trying to educate people and even do some of their own farming and that kind of thing. So it's not just one thing, it's all of those things together and how they interact. And one thing that does not get enough exposure is, no pun intended, is actually the environmental hazards. Ms. Thelma, you live in Southwest, and that's a place where there's been a lot of gentrification, a lot of construction, right? Well, who are the people that are being exposed to all the toxins, right? So there are actually many avenues, and it becomes very important if we're going to improve the health of a group or a community or a neighborhood, that we really have to look at all of these things. It's not one thing, but rather all of these things together, because that's a particular issue. But I'm going to share with you an area that most women don't know is a significant risk factor, and that is alcohol intake. So, and alcohol is beer, wine, or hard liquor. It doesn't matter. Women, we metabolize alcohol much more slowly than men. So remember, maybe you remember when you were growing up, all those myths that it takes less alcohol to get a girl drunker, right? That's actually true. So for women, we say that no more than 7 drinks in a week. Men, it's actually 14. So what is a drink? A shot is equivalent to a glass of wine, is equivalent to a can of beer. Why? Because even though a shot is higher in alcohol, what you do with a beer is you're making up for volume. And apropos to the sizes of beer that is sold in communities of color, it's not the smaller can, it's those big, cans that are sold. So you might be having 1 beer when it's actually 3 beers, right? So there are many, many different aspects, but that's one of the things that I wanted to make sure that the people that are listening are aware of, is the role of alcohol, because nowadays, many, many people, you hear it mentioned all the time, oh, let's go for some wine and relax. That's becoming much more acceptable among women, and that is a risk factor. So as we close, I want to give each of you an opportunity to kind of share any final thoughts. And I think we'll start with you, Ms. Stark.
Thanks so much. So again, thank you so much for letting me be a part of this conversation. I feel like I'm learning so much from everyone, but I really want to encourage people to have those conversations. Like Ms. Jones was mentioning, and going out to the younger generation, that's what I'm seeing too. In COVID, our numbers for genetic testing have actually increased. And in part, I think it's because young women, young men are going to their communities, they're going to their aunt's house, their grandma's house, and saying, listen, this is a family conversation. This doesn't have to be taboo. We can talk about this. And they're actually helping, get them on the Zoom calls so that we can get around the transportation issues and all of that. And so I really think, this young generation coming up, they've got the right idea, and as much energy as we could put into them, I think they're going to make a big difference.
Thank you. Ms. Thelma.
Thank you. And thank you so much for the invitation to be here. I've found this a rather interesting and great learning opportunity just for myself to share information with the Thelma D. Jones Breast Cancer Fund. But I second what you said earlier, basically where we live, our zip code should not have to determine whether we live or die or the quality of our lives. And there are so many people in situations like that. And you mentioned about Southwest, where we learn, and the huge environmental impact there of the gentrification and all of the buildings that's going on. Southwest, as many of you do not know, has the largest concentration of public housing in the District of Columbia. So there is a lot that has to be done when you talk about a zip code, when you talk about environmental issues and the social determinants of health and the other challenge. The Thelma D. Jones Breast Cancer Fund is still trying to work one woman at a time, one child or student at a time, to help change the paradigm shift of the challenges of breast cancer in our community.
Thank you so much. I mean, such rich information from all of you. Dr. Kendra, what are your closing thoughts?
My thoughts are that, education on every level. I think that as we think about, and that's what I'd like to do with Uzima Health and Wellness, is how can I educate and reach a spectrum, everyone from, Ms. Stark should get something from Uzima Health and Wellness, to Ms. Jones, to you, Dr. Gigi. And, it takes a lot of work to make this bridge, but we can all come to the table. It takes an interdisciplinary conversation. And when we think about education, we have to educate on the community level, making sure that we are using the type of language and messaging that is appropriate for each community. And then we have to educate physicians and nurses, our medical community, to be sensitive to the community they serve. I think that that is a much needed area in terms of being impactful. We talk about medical education and how we need to change the way medical students look at certain patients, how we make referrals for certain patients. That is something that we can change almost instantly. Through checks and balances, we have quality assurance committees that can go to work and make sure that that is being done. And then finally, we also need to find people in our community, our city planners. You know, for 20 years, we've been going through gentrification for major cities. We have closed down hospitals. We have closed public health centers that used to be the bedrock of community information. And I think President Obama was one that said, you know, we have to get back to civics and learning and understanding civics and our civic duty to each other. And that does include health. It's not a separate conversation. So I think that, you know, my whole point is about education and communication. So thank you for inviting me. I just learned so much from every one of you all, and I look forward to speaking to you. And I'm going to find you, Ms. Jones.
Thank you. I'm easy to find.
Yeah, Ms. Stark. We're going to talk some more.
Thank you.
Well, you know, one of the things as we close out that we're doing at the Rodham Institute is that actually we are partnering with Pennsylvania Avenue Baptist Church for one project and Temple of Praise for another project, where the congregants are actually going to be helping to create a curriculum to teach our learners what are the most effective ways to talk about whether it's colon cancer or breast cancer. What are those barriers so that they actually have a voice in the education, which I think is going to help to sort of shift that. It's all about the control and the power when they're educating us, because they know best. We could talk forever, but our time is up. I'd like to thank each and every one of you for joining us this evening and look forward to continued conversations and continued work. Thank you so much. And please tune in again for the next Rodham Institute speaker series. Have a good evening.
Nice.
Bye-bye.
Thank you.
Bye.
Thank you.
Bye-bye.